Black Doctors Podcast.
Hello and welcome to the Black Doctors Community Podcast. I am Dr. Stephen Bradley, your host. By training, I am an anesthesiologist and critical care medicine physician. That means I completed medical school, I completed residency in anesthesia and fellowship in critical care medicine. I practiced for several years in the United States military, and now I practice in more of an academic setting. We'll talk more specifically about that in later episodes. This month, I want to kind of introduce myself to you and talk about what my plans are for this program and what motivated me to start this series. For the past 4 years, I have hosted the Black Doctors Podcast. Every Monday, I publish an episode of the Black Doctors Podcast. The theme of this show is to provide representation, so I interview Black and other minority physicians, and I share their stories with the goal of increasing diversity within the healthcare workforce. I want to inspire that next generation of Black and brown physicians. We know, based on the medical literature, that healthcare disparities exist. They exist for many reasons, from different ethnic groups to socioeconomic differences in status in terms of finances, levels of education impact healthcare disparities, insurance status as well. All these factors are proven in the literature. We know that there are different reasons that different groups of people, especially in our country, have different healthcare outcomes. With all this research, some of the ideas that have been proposed or recommendations to help fix these healthcare disparities include increasing diversity within the healthcare workforce. So our physicians, our nurses, we need more diversity, and that can help improve the healthcare outcomes of these folks, of people that are having worse outcomes with their healthcare. That is a large part of what inspired me to start the Black Doctors Podcast. About the same time that I started the podcast, I also launched an Ask the Anesthesiologist YouTube channel. I kind of bit off more like a chew. It was very busy. I was learning a lot. So if you go back to some of those old videos, you'll see how I didn't really know about how to do audio editing and video production. So the quality was a little rough, but thank you for tolerating that, those of you that watch those videos. I've learned a lot in the last 4 years and wanted to do this spinoff series to really talk to people that aren't in healthcare. The Black Doctors Podcast really typically targets people that are looking for a career in healthcare, or maybe they're medical students or resident physicians in training. And I realized that I want some of this information to go directly to people that are not in medicine, that are in the community. These are the patients that we will eventually see. These are the family members of the patients that we take care of. And I want to talk specifically to you. So this is for you. And every month, I'll plan on releasing an episode. And eventually, hopefully, we'll have some guests from different medical specialties. And every month, I want to provide some information that will be helpful, that may impact the quality of care that you or your loved one receives. And it may help, save some lives. This will not be any medical advice. This will just be general healthcare information from a trusted source. A little bit more about my background. So to become a physician in the United States, it requires completing college, and specifically, there are certain courses that you have to take in advanced sciences. After doing that, you can apply to medical school. Medical school is 4 years. You complete 2 years of book work mostly, where you're taking tests and doing exams and having lectures. And then generally 2 years where you're in the hospital as a medical student. You're working on rotations and you're seeing patients under the supervision of resident and attending physicians. Once you finish medical school, you then apply to residency training. Residency training ranges in time from 3 years to 7 years, depending on what you choose to specialize in. This is when you become those different types of physicians, from an internal medicine physician or a family medicine doctor to an obstetrician and gynecologist or a surgeon or an anesthesiologist, all these different medical specialties. So residency ranges in time from 3 years to 7 years, like neurosurgery, 7 years of training. And then after completing residency, there's often the option to do additional training, which would be called fellowship training, and you can be subspecialized. So I am subspecialized in critical care medicine. So I did residency in anesthesia. and then a critical care medicine fellowship. We'll talk in a different episode, probably next month, about the different roles of the people that you will encounter in healthcare and in the healthcare workforce. But this week, I wanted to first make that introduction, talk about why I want to start this project, these monthly episodes of the Black Doctors Community Podcast, to talk specifically to you, to your loved ones that aren't directly working in healthcare. I plan to release these episodes on YouTube, but they'll also be available in the podcast format, which you just need to go to whatever podcast browser that you typically use. If you have an iPhone, then Apple Podcast is an app that you can go to. You can search for Black Doctors Podcast. You can subscribe and get the episodes there. You can use Spotify. There's a host of other applications out there that you can go to. You can download these episodes and it'll just be the audio. It won't have the video component. So it's great to listen to on the go. This week on the Black Doctors Community Podcast, I want to talk about how to navigate the healthcare system. And I know it's a very broad topic, but I figured I'd break it down by talking about the different levels that we have in healthcare. There's, you think of the typical standalone community hospital, or maybe you think about an academic medical center like the Harvards or Yale or University of Chicago or whatever city you're in. But I understand that across the United States, there's different levels of access of care that is available. If you're out in a very rural community, then there's probably not the patient volume to support a very large hospital. So out in the community or in smaller communities, you typically have smaller hospitals versus if you're in the inner city. And people wonder, why do you go to specific hospitals, one versus the other? There's different levels of trauma care, whether you're going to a level 1 trauma center, where you have access to level 2 or level 3, or you go to community hospitals. Sometimes you have to have loved ones transferred to different hospitals. But I want to kind of explain what some of that means. Probably, and my goal is not to offend, but I do want to simply break down a lot of this information at a level that people can understand and digest, and again, maybe potentially helpful. So I hopefully don't offend anybody working in healthcare or your community. It's definitely not my intent. And I will remind you that this is not medical advice. So maybe the lowest level of acuity. Acuity just kind of means how critical or how sick somebody is. On the lowest level, it may be your outpatient physician. So you can go see your family medicine doctor or your pediatrician. Pediatricians are doctors that specialize in working with children. You can go see your internist. Internal medicine physicians also provide this primary care. On the other hand, there are also nurse practitioners and physician assistants that work in this primary care space as well. When we say primary care, we're kind of talking about that first level of interaction that you may have with the hospital or with the medical system. Primary care is the first point of contact for you as a patient when you interact with the healthcare system. And again, it involves all those people from different specialties and different trainings. They're trained to provide care for a wide range of health issues. They provide this comprehensive or the full and continuous care, and they kind of manage your overall health. So you can go to the primary care physician. You should see one annually. So every year you should go see your primary care doctor or primary care provider, if it's a nurse practitioner or a physician assistant. But you want to see them every year for a scheduled checkup. They'll be able to look over your vital signs, so check your blood pressure, your heart rate, how quickly you're breathing. Do you have any aches or pains that need to be looked at? Do you have any lumps, bumps, bruises, things that are swelling that they need to keep an eye on or track? There are maintenance exams. So every couple of years, just like you take your car to get serviced at 30,000 miles or whatever, the healthcare system we've built in, we should be looking for these different conditions at different ages. Maybe at a different episode, we'll break some of those recommendations down. We'll get a primary care doctor on here so we can talk about those. For pediatrics, for the kids, at certain years, they're supposed to get different vaccines or different medications or different disease processes that you can expect at different age ranges. So it helps to go see a primary care physician to get that outpatient care. If you have a history with them every year, they'll be able to pick up when things change in your medical history and catch things earlier, catch disease processes, while there's still small issues that can be changed, oftentimes with things like changes in your diet or changes in your activity level. We don't have to necessarily throw medications at all of these illnesses. If we catch them early enough, we can usually avoid a lot of these downstream bad things that can happen. So ideally, you'll go every year to your primary care physician. You'll get outpatient follow-up, annual checkups, and visits. They're going to monitor your health. And then if you have medical conditions, they can usually manage those on an annual basis, or maybe you need to go see them every couple of months. So chronic, there's chronic and acute conditions. Acute is kind of short term, but chronic is something that you live with for a long time, like maybe high blood pressure or diabetes. And you can go to that primary care physician for close monitoring of those chronic conditions. So primary care and outpatient medicine, you want to do your yearly physical exams and then follow-ups. You usually go to like maybe a shopping center or a clinic, and it's outpatient. You drive up, you park, you walk in for your scheduled appointment. They'll check your vital signs. You'll see your doctor, and then they'll make some recommendations, and then you leave. Maybe you see them in another year. Maybe you follow up in a couple of months if they change the medication. That is primary care. Probably the next level up, I'd say, is urgent care. This is a walk-in clinic that you can go to for a non-life-threatening medical issue. Again, this is not medical advice, but maybe you need some quick care for something that's not your diabetes or high blood pressure, something that's long and chronic. Maybe you have a cut that may need some stitches, or you sprained your ankle. Maybe your kid is sick, has a fever, or maybe you have some infections or bad headaches. You can go to urgent care. Usually it's a lot shorter of a wait time. Urgent cares are staffed with different specialties, from family medicine doctors to internal medicine doctors to emergency medicine physicians to nurse practitioners or physician assistants, typically. And they're able to manage a lot of these things on an outpatient basis as well, but they're a little more acute, short-term issues that they can look at, treat you, and then you can walk out. It's important to know you got to know the difference between the urgent care and emergency department. If you go to an urgent care and whatever issue you're having is too big of an issue for urgent care, then they'll likely refer you to go to the emergency department. If you're really sick, they may say, hey, we need you to not drive. We're going to call emergency medical services. We're going to call an ambulance and transport you to this emergency room. But that's kind of at the discretion of that urgent care or whoever you're seeing. The urgent care can only take care of so many things. If you're in a bad car accident or have a gunshot wound, or you're just really, really sick, or you're concerned of a stroke, then maybe instead of going to the urgent care, you should go to the emergency department, or consider calling emergency medical services as well. Again, this is not medical advice. This is all information that you can find on the internet. The emergency department is kind of that first step into the actual hospital side of medicine. There are freestanding emergency departments that are staffed by emergency medicine physicians and other specialties that can take care of some more acute issues, but oftentimes they're attached to an actual hospital. It's kind of the entry point for inpatient care. The emergency department is the place you go for serious, life-threatening conditions, and they can provide immediate care for those. So oftentimes, there are times where you can go to the emergency department because you need to get seen. Maybe urgent care is closed. Other times, you're being brought in by an ambulance or emergency medical services because you were in a car accident and you're incapacitated, or you don't have the ability to make medical decisions, or your family member, and they'll just pick you up and take you to the emergency department because you need to get that higher level of care. Things like having a heart attack, you're having crushing chest pain, you're thinking, maybe I have a heart attack. You would go to the emergency department for that. If you're having a stroke, there's signs and symptoms of like slurred speech and a facial droop where time really matters. Severe injuries or breathing problems. You've probably seen the movie Hitch with Will Smith, where he had an allergic reaction. You're having trouble breathing, your throat's closing and swelling up. Well, then you want to go to the emergency room to get checked up because you have these very acute, critical issues. Unfortunately, a lot of times, depending on how sick you are, you may have a longer wait time. Because the emergency department is dealing with life-threatening conditions, they have a triage system where they're going to deal with the sickest patients first, because I think we'd all understand that if you're just there, not if you're just there, but if you're there because you broke a bone in your arm, but somebody else is having a heart attack, they're going to treat that patient having the heart attack first, and you may be waiting a while. Maybe while they're almost done treating that patient with a heart attack, somebody comes in from a car accident. Well, then they have to shift their attention to that other patient, and that can lead to long wait times that we unfortunately know are part of emergency medicine. Oftentimes, also, patients that don't have a primary care physician that they're seeing every year, or that kind of bypass their urgent care, they may go to the emergency department, and that can contribute to long wait times as well. So that's why one of the reasons it's important to have that yearly visit, that yearly checkup, to make use of the urgent care systems as well, because that can help alleviate or decrease the wait times in emergency departments. That emergency department is often your first step into the hospital. Maybe you have pain in your stomach and you have appendicitis, an inflamed, infected appendix. Well, the emergency department, those physicians will consult other medical specialties, whether it's internal medicine physicians, ICU doctors, they'll consult surgeons. So if you have that inflamed appendix, it's infected, they'll do some studies and tests, they'll get an ultrasound or a CT scan. Then they'll call the emergency medicine or the general surgeons. The general surgery team will come down, they'll take a look at you, they'll make a diagnosis. Okay, your appendix is infected, we got to take it out. And then, you may be admitted for observation while they wait to take you to surgery. We'll talk about, there's two types of surgery. There's like inpatient and outpatient surgery. Outpatient surgery, you can go from the emergency department to the OR, have a very short, kind of not very invasive. All surgery is kind of invasive, but some surgery requires a longer recovery period than others. So you may have a surgery that you can go to the emergency department, have surgery, and then get discharged that same day or maybe the next day. Sometimes you have to stay longer. So there is outpatient surgery, just like I talked about, kind of outpatient clinics, and there's inpatient surgery. Outpatient surgery, there's even outpatient surgery centers where maybe you're getting your tonsils taken out, or maybe you're having carpal tunnel or a bone broken and that is broken being fixed, where you can show up the day of, go to surgery, and then leave that same day. You need a driver because you'll have anesthesia. But there is same day or outpatient surgery, and then there's inpatient surgery as well, where maybe you need thoracic surgery where they're working on your lungs, and they need to observe you for a couple of days afterwards to make sure everything is okay. So there are two types of surgery in that setting, but we're back in the emergency department, right? And you had to have surgery. So they may actually admit you to the hospital, to what's called inpatient care. Inpatient care is you're staying in the hospital overnight. You have a hospital room. I think back in the day, they used to have wards where it's just a big open room. Maybe you're separated by curtains. The push more recently has been to consolidate. So most hospitals, you're going to have single occupancy rooms where you're the only person in the room. Depending on the hospital, I've also seen double occupancy where there's two patients in the room divided by a curtain. But we're definitely trying to push towards the single patient per room. And there you're going to stay the night. Your admitting team, you may be admitted by the internal medicine physician. You may be admitted by the general surgeon. That just means that your admitting physician is who is in charge of your care. They're going to put in orders. They'll say what you can or can't eat. Maybe you're going to surgery eventually, so you can't eat 6 or 8 hours before surgery. Maybe they want to observe your stomach, so they're not going to give you full food, and they'll just give you a liquid diet. There's different medical orders that the team will put in, and you'll be under care in the medicine wards. You'll interact with patient care techs or medical techs. You'll interact with nurses, physicians, advanced practice providers, nurse practitioners, or physician assistants. All these different people you may see when you're admitted to the hospital. Depending on why you're admitted, that can determine how long you're going to stay. And, it's a daily conversation. Oftentimes we're getting additional lab work or studies, and we're still trying to figure out what exactly is going on, how bad your condition is, and that will determine your length of stay. So we may not have all the answers immediately, but as time goes by, then we get better and we get closer to having an answer and maybe knowing when you might be able to leave the hospital. We talked about inpatient care. Again, we're requiring, we need to stay in the hospital because you're a little more serious than just going to the clinic or going to urgent care and leaving and be able to go home. We need to watch you. Sometimes maybe you need to recover from surgery that you had, or you had a really bad infection where you need IV antibiotics, or you need closer monitoring. And when that's done, then you'll be able to ideally be discharged home. Sometimes if you're really sick, you may need to go to a rehab facility first, but that's typically what inpatient medicine is. Finally, I get to intensive care unit or critical care medicine. That's what I'm so specialized in. An ICU or intensive care unit is the area of the hospital that is reserved for the sickest patient, the most critically ill patient. And in the ICU, we provide specialized treatment. We provide more invasive monitoring. Our patient ratios are lower. Probably most importantly, we have a limit on the number of patients each nurse can manage. So oftentimes it's one nurse to every 2 patients, maybe to every 3, depending on the acuity hospital. So you get a lot closer nursing care, and the number of patients that the physician is taking care of is usually lower as well. And you'll be staffed usually by an ICU trained physician. Things like having a breathing tube and requiring a ventilator, having large IVs, we call them central lines. Those are often required to stay in the ICU because with more invasive treatment, there's a higher risk of complications that can occur. We need to watch you closely. Things like medications that maintain your blood pressure or heart rate, or maybe you have a really bad infection that we need to monitor very closely. So severe infections, if you had a really big surgery, you may go to the ICU for close monitoring. Life-threatening conditions, you had a heart attack that we need to keep an eye on, and it requires constant monitoring. That will go to the ICU. One of the terms that gets thrown around is, so-and-so is on life support. Life support is generally, it's a very broad topic or a broad word to use or a way to describe it. But the things that I described just now are life support. So medications, because sometimes your blood pressure, if you're really sick, gets low to the point that you're not pushing blood or oxygen to your brain. So when that happens, we have medications that we can provide through an IV to make sure your blood pressure stays high enough to perfuse your brain and get oxygen and blood flow to your tissues, your important organs like your heart and your kidneys and your lungs. That requires care in the ICU. And that is also considered life support. Life support includes things like the breathing tube. I know that's a big deal in COVID and ventilators. That's considered life support. We may have invasive blood pressure monitoring. There's a monitor that we can use to check your blood pressure with every beat of your heart. That is in the ICU. We may have a catheter, a tube in your bladder to monitor how much urine you're making. How much urine you're making shows us how well your kidneys are working and how sick you are or how much you're improving. So all those things are occurring in the ICU. And all those things can also be described as life support. Another term that gets used is a coma, or you're in a medically induced coma. A coma, it's usually being described that your loved one is not able to communicate back and forth, would be probably the way I would describe it in common terms. Maybe your loved one is less interactive than normal. And there's 2 types of comas, I would say. There are the medically induced, and then the ones that are just caused by somebody being that sick. So sometimes if you had a stroke, or if you've had a bleed on your brain, or maybe you're in a bad accident and you have a concussion, or your brain is kind of bruised, or you had a stroke, you may be a lot less, or maybe a lot less interactive, and maybe in quote unquote a coma. And that's just a waiting game, and maybe there's different medical interventions we can use. Oftentimes, like maybe after surgery, where the breathing tube is still in, or if you're really sick, usually it requires a breathing tube. We will have medication, so sedation medication that keeps the patients nice and calm and sleepy. Breathing tubes aren't painful, but they are uncomfortable. You can imagine having a tube down your throat. It's not super comfortable. So we do usually provide some sedation, and that may be considered a quote-unquote medically induced coma. So being able to clarify those terms, if someone tells you that your loved one's in a coma or on life support, you can hopefully now, ask several questions like, is this a medically induced coma, or are they just on sedation medication because they're that sick or they have a breathing tube? Or is it a coma where they're not waking up for some other reason, because they had a problem with their brain or because they're too sick and have a really bad infection. Or if they say that they're leveling on life support, you can ask questions like, what type of life support are they on? Is it the breathing tube or ventilator? Because if they have a breathing tube, then they're probably on some sedation medication as well. Are they on medications to keep their heart rate up or their blood pressure up? Are they on medications to treat bad infections? And the next question you can ask, it's a big word, what is the prognosis? Or what is the expected outcome? That answer may change depending on the amount of information that the medical team has at that point in time. But, as we get more information, we can oftentimes make, I don't want to say a guess, but kind of an educated guess, right? Based upon our years and years of training and the patients that we've seen and taken care of, what is the expected outcome or trajectory of this illness? So those are kind of some of the questions that you can ask. So I know I talked about a lot of information. Feel free to, go back and re-watch this video, share it with somebody that you think may find it helpful. We talked about the different levels of the hospital system, from outpatient to urgent care to the emergency department to inpatient care. We talked about the difference between outpatient and inpatient surgeries, and then the intensive care unit and kind of what it means by being on life support or in coma. Thank you for tuning in. Hopefully you found this helpful. I plan on releasing one of these Black Doctors community podcast episodes every month and digging into topics and conversation like this. Feel free to leave comments or questions below. I'm going to apologize in advance because I do have a very busy work schedule. When I'm in the ICU, I'm usually working 7 12-hour shifts in a row, an 84-hour a week. And then I'm usually kind of trying to recover from that the next week. And I do a lot of other stuff that I like to do between the podcasts that I release episodes of every Monday. And then I also love to make music. So I'm going to apologize in advance if I'm not able to answer every question. A lot of questions that I get online, I cannot ask because I cannot provide medical advice. We do not have a real patient-physician relationship. So I'm unable to answer those questions about specific medical conditions. If you haven't already, like and subscribe so you'll be notified when I release new episodes of the Black Doctors Community Podcast. If you know of somebody interested in becoming a physician or working in healthcare, please send them to the Black Doctors Podcast. Again, every Monday I have episodes that feature really inspiring physicians, people in healthcare who have very inspiring stories of how they became physicians. So definitely please share those. And finally, I really love health and wellness and mindfulness. And maybe the answer is not always medicine. Sometimes, just a change of environment, being able to meditate and be at peace with yourself. I really am aware of how music and sound can change your mindset, can treat different medical conditions, and at least make you feel more at ease and treat some of the decrease the stress that the world we're living in is so stressful. So I try to create music, like ambient, peaceful mindfulness music that helps set a space for us to relax and reflect. And you can visit that YouTube channel, Ambient RX. I'll probably put a link somewhere on this video. You can go there, and every Monday I put out a Mindfulness Monday, a sound bath type video. I'm looking forward to making more of those to help with relaxation and mindfulness and peace and tranquility. So if there's something you're interested in, check out that YouTube channel or follow me on Instagram at Stephen Bradley MD. Thanks for tuning in to the Black Doctors Community Podcast. I'm Dr. Stephen Bradley, your host. I'm here because representation matters.